So welcome everyone. I'm Elizabeth Krupinski. I am the Associate Director of Evaluation for the Arizona Telemedicine Program and the Co-Director of the Southwest Telehealth Resource Center. I would like to welcome everyone to our series Improving Access to Quality Medical Care webinars. It is presented by the Southwest Telehealth Resource Center, the Arizona Telemedicine Program, and the Arizona Department of Health Services. Next slide. So welcome everyone, especially those of you from our Southwest TRC region, those in Arizona, Utah, Colorado, New Mexico, and Nevada, any fellow HRSA grantees that are out there, and everybody else who decided to join us on this important talk today. Next slide. So the Arizona Department of Health Services, the ATP, and the SWTRC, we welcome you. This is a free webinar series that we've been putting on for quite a while now. Acknowledging the fact that the practice and delivery of healthcare is changing, changed dramatically over the past 18 months and will continue to do so. And we put an emphasis on improving quality, safety, efficiency, and access to care. And we think telemedicine can help you with these goals. Next slide. So some tips and hints and notes and all that kind of good stuff, basically just some housekeeping. When you join the webinar, your phone and/or your computer microphone was automatically muted by us. Time is reserved at the end for Q&A. Please use the chat function to ask questions. And I'll go back and look at these, keep track of these, and then moderate at the end. And Carol's going to give us all the wonderful answers. Please, once the webinar is over, fill out the post-webinar survey. There'll be a link that automatically takes you there. This gives us feedback about the webinar, the topics, and any future topics that you might be interested in. As you noted when you logged in and said continue or don't continue, the webinar is being recorded, and we do post these on our ATP website, and you can see the link there. Give us a couple days because it does take a little bit to transform these into something that we can put on the web. Next slide. So it is our pleasure to have once again as our speaker, Carol Yarborough. She is a healthcare compliance and reimbursement specialist. She's talked a number of times in our webinar series and office hours, each time on a new and exciting topic. She provides a unique background in legal, technology, revenue management, clinical management, and both federal and state regulations. She's done this for at least the past 4 years, and has actively contributed to a number of telehealth initiatives at UC Health. She works hands-on with professional fee and hospital-based fee professionals to implement billing strategies, because it does take some strategy to implement telehealth billing, and provides real-time feedback to clinicians regarding documentation and staff with encounter guidance. She also trains CPT coding professionals at UC Medical Center to maximize EMR workflow with greater documentation and coding. So today we got an alphabet soup: CAHs, FQHCs, and RHCs. Oh my, it is an oh my. And I turn it now over to Carol to tell us what this alphabet soup is all about.
Yeah, definitely oh my. Here's my disclaimer. Usually it's, the disclaimer usually deals with my bad jokes and puns, but they're all my opinions, and I felt particularly with this subject matter, I did want to give our lovely organization sponsoring this webinar an out due to any inaccuracies I may convey during this, because a lot of this is not my firsthand knowledge. I work in a fee-for-service world primarily as a pro-fee coder. So I just wanted to bring these things to light. I learned so much doing this, and I hope you do too. So the agenda today, and I'm going to, well, let me know if the background noise gets a little bit too much. The dish or the clothes washer sounds like an airplane. Okay, so the agenda: where did these healthcare centers come from, and for what purpose, or what we're going to be talking about. Payers, primarily Medicare in Arizona, and then what's going on with the PHE telehealth and post-PHE telehealth as they pertain to these particular healthcare providers, and then I'm giving you a big long list of references, and of course we'll deal with questions. So just to give an orientation, the CMS list is followed by all payers, and a CMS list of places of service for the designation of where you're practicing medicine or where you're providing medicine. And it goes on the CMS 1500, which is a pro fee bill. Now, in the instance of one of our service providers that we're going to be talking about, things go on the UB04, which is the CMS 1450. But I just wanted to orient you to the different places of service we have here. So what we're going to be talking about are found my own typo. Inpatient hospital, which is place of service 21. Everyone can stop typing in the chat box like I made a mistake. And then we have the FQHC, which is place of service 50, and a rural health clinic, which is 72. And even though one of these organizations bills primarily on the UB04, if a provider chooses to not assign their billing rights to that organization, they can bill on the 1500 while that organization will actually bill on the UB04 still. Sounds very cryptic and leading. I know you're all dying to know how that happens. So first we're going to talk about the critical access hospital. So a little bit of background about how all this came about. So the prospective payment system was created in 1983. We went from cost-based reimbursement from Medicare to prospective payments. And so they decided, for pneumonia, we're going to pay each organization based on their geographic area, and, malpractice, we're going to adjust the DRG payment for each geographic area. But, basically pneumonia is going to be an inpatient stay for a patient, probably, I don't know, the doctors in the room here, let's say 7 days. You get everything taken care of, and they assign a specific payment to that, the hospital bed, the room, the supplies, everything goes into that DRG. And then it's billed out on the UB04. So that's prospectively, like, if your patient is the first diagnosis code you put in for your DRG payment, and then you put it into the grouper and it comes out pneumonia, you're going to get paid this one reimbursement amount based on the diagnoses you submit into that grouper, which is way better than trying to figure it out when you list all the diagnoses and then go to the book and try to figure it out. I know inpatient coders just have it a little bit easier than us pro fee coders. I'm kidding. So anyway, so critical access hospital, place of service 21. So during the 1980s and 1990s, hospitals were all closing down because the PPS system wasn't covering the costs. If you're in a rural clinic and all you have are people admitted for pneumonia, you're not going to get that big payment you would get from a heart transplant. You wouldn't get that big payment from a liver transplant to kind of, soften the blow from all those pneumonias. So this is where you're becoming dependent on hospital admissions for your bottom line. And so the Balanced Budget Act of 1997 created the critical access hospital provider type. So it's a place of service. It's a setting. So they receive cost-based reimbursement for all services. And for the actual setting, they get paid at 101% of costs on the Medicare business. Now with their private payers and maybe Medicaid, they'll get paid at a flat fee, or maybe they're going to get DRG reimbursement. But for Medicare, they get 101% of costs. And this is done by looking at an average of what their costs are over a given year, I think. This is very complicated to me, but fascinating. So the next step on that is the swing bed concept. And I never really understood that either. Are you so glad you can come to this webinar and hear me talk about what I didn't know and what I'm still confused about? But I just want you to know we're all there together. So any question at the end, I may be able to answer or maybe not. But anyway, so hospitals with 100 beds or less, you can keep that patient in that bed. And once the hospital discharges that patient in that bed from acute care, or like I'm discharging you from your pneumonia, or I'm discharging you from your broken hip into a skilled nursing function, patient doesn't have to get up and walk to another part of the hospital. They can just stay in that bed and the services come to that patient. And then, you know, it makes sense. Patients must be in the medically necessary acute care bed for at least 72 hours. Well, it fits with that 3-day sniff thing. So that made sense to me. Eureka. This is all leading up to the fabulous critical access hospital, you know, denouement. So there are payment methods where you bill the MAC for everything. So both facility, both pro fees. And like, as I mentioned before, the physician reassigns all of their outpatient billing services to the critical access hospital, everything. And this is where one of the attendees had corrected me before, where I was like, oh, well, the critical access hospital may be connected to a rural health clinic. No, this is just separate entities, even if they're associated. So it's only critical access hospital outpatient services. So setting specific. Because if they see that patient in the rural health clinic, then they're going to do that other kind of billing, that mysterious billing. All right. So for facility, 101% of reasonable costs. And if you look at the list of the reasonable costs on the CMS handout, the URL of which I included in resources, you know, it's typical. Like, you know, you're paying for air conditioning, you're paying for stuff, you're not paying for entertainment. And then for pro fees, you get paid at 115% under the Medicare physician fee schedule. So we are kind of getting into the Medicare payments, but that's the physician fee schedule as opposed to the DRGs. So 101% of cost for facility, MPFS at 115%. And then for NPPs, and I imagine other kind of people that can do incident too, there we go, I imagine, 115% of the allowed amount under that as well. So here we're getting to telehealth. This is all about telehealth. So this is during the PHE, and we all love those FAQs that seem to be steadily growing even as certain states are opening up and we're starting to be able to, you know, leave the house without a mask, some of us. So this is where everyone was URL. Sorry, just had a weird thing pop up. They said that they do not have to be physically present, and it's going to be through direct radio, like walkie-talkies or a CB radio, I guess, or telephone communication or electronic communication for consults, assistance with medical emergencies, or patient referral. So, the doctor doesn't have to be there. It's going to keep everyone safe. And the thing is, this will end at the end of the PHE. Not to panic. We're opening up. People are going back into their workplaces, quitting jobs, getting new jobs. We're going to get 60 days notice before the feds decide the PHE is over. So these are some of the pertinent questions I thought you would find interesting from that FAQ, because the document itself is really long. You can see we went from page 10 to page 89. I think it's like closer to 200 pages. So there are types of bills for hospitals. Now, I learned about a type of bill reviewing Medi-Cal's reimbursement regulations for telehealth as well. They want type of bill O2 for hospital services for telehealth during the PHE. And I think just even in general at this point. So should the hospital submit a separate O12X type of bill for the originating site? Yes, they should. Let's do it. So you get that originating site facility fee if you're providing telehealth. Say the patient is, in the hospital, your provider's at home, you submit that Q 3014 on the UB04. Jet engine's taken off. My washer's on the spin cycle. Okay, outpatient therapy services. Can the outpatient therapy services furnished in a CAH under Part B be reported on a UB04? Yes, fantastic. They're separately paid, and they're not included as part of that bundled institutional payment. So it's not like they're considering this not part of that reasonable cost and expense. They do want it reported on a type of bill 85X, and you separately provide and bill for physical therapist, occupational, SLP. So they want this on the different bill type. It's not going to go on the usual reasonable expense deal. So how do I bill for this stuff? See, that's always the question. Yeah, go ahead and bill. Then the next question is, how do we do that? So there are two options. Okay. So you do the stuff that's on the telehealth list, right? There are what now 188, 189 CPT codes on there, and you put them on the UB04 with a modifier 95 in each line, because there's no place of service required. There's no location for it on the UB04. It's a hospital outpatient service. So by putting 95 modifier on it, you're telling CMS it's telehealth and you're not in the hospital or in the patient's home with them doing therapy. So they know it's telehealth. They brought back, we've talked about this before, they brought back the 95 modifier for CMS during the PHE. Second option, hospital without walls. And I'm hoping this is old hat for you guys at this point. I hope I'm just reassuring you at this point. And if not, go back and bill for the last year. What, CMS is 12 months, right? 18 months. Just go back and bill. Hospital without walls, you register the patient as a hospital outpatient, and that patient's home then becomes part of the hospital outpatient department. Great. So you bill it as if therapy had been furnished in the hospital. You put on a PO or a PN modifier because it's an off-campus department. And then 85X is your type of bill. 95 modifier. But the difference is the POPN. Now what that does for you is you get the hospital facility fee that you would normally get with, and you're not billing the originating site fee, that Q3014. So say there's a certain component, even they get something medically done or medical advice from a nurse practitioner, and they also get physical therapy that same day. That hospital without walls means you can bill the facility fee. not in a critical access hospital. See, I'm going into my fee for service, fantasy land. Okay. This was a question someone posed, and I consulted with folks at the Center for Connected Health Policy, who then reached out to Thems That Knows. And we did determine that RPM could be billed from a critical access hospital. And I don't know if I put this into our RPM presentation or not, but it's good enough to repeat again. So let's do it. So you receive the cost-based reimbursement for those 2 practice expense codes. You bill them on the UB. And then if you've reassigned your rights to the critical access hospital, then they bill the 99457 and 58 as well on the UB04 with the 95 modifier. RPM went general supervision even without the PHE over a year ago, so you're fine with that. And the incident 2 stuff, the general and supervision, is even kind of easier at a critical access hospital because everyone's being paid by the CAH. So if you have, one of your auxiliary staff, you've got a great, person who does training or is really great with patients, they can, walk them through, maybe you FedEx a blood pressure cuff to their home, get on a video or an audio call and you train them on their blood pressure cuff. When am I grabbing my wrist? The better one's the armband. We know this. So that gets billed out. But then if that person also does other kind of, communication with the patient and other kind of care management during that 30 days that you can bill those codes every 30 days, that time can get added in by that auxiliary staff. Anyway, under general, don't split and bill a technical, true. Codes are placed on the physician fee schedule. No method to bill them as a facility service, true. Can still go out on the UB04. But if the pro fee work is where it's, okay, it's telling me not to do it. See, I'm telling you, I wrote this up yesterday. Method 2, it would be billed on the UB. Right, that's what I just said. But method 1 would be billed on the 1500. That's if your provider does not assign their rights to the CAH and prefers to bill their own stuff. Maybe it's a medical group that's working at your critical access hospital. They don't assign their billing rights, so they bill that stuff out on the 1500. Not contradicting myself yet. Okay. So that was clear, right? I'm not even going to read the chat questions yet. So FQHC. Place of service 50. So this was established in 91. So that was Balanced Budget Act. No, yeah, 1987. First we had the CAH. Then in 91, along came the FQHC. Stringent set of requirements, sliding fee scale, governing board, including patients. You can have all these other types of names and types of entities. It's still a FQHC. And the defining legislation is under the Social Security Act. That's where you can find out more about it on the HRSA site. So FQHC is a reimbursement model, not a place. Now the CAH was a care setting. So an FQHC can be in an urban setting, it can be rural, but it's a reimbursement model. It's not saying, well, if you are out here, and you've got 100 beds or less, and you're not within 35 miles of da-da-da, you can have an FQHC anywhere. So you meet all those requirements I just listed. So these are cost-based, again, or cost-derived basis than published fee schedules. Again, a mystery to me, to learn that even an FQHC in San Francisco you perform some kind of dermatological procedure, but you've assigned your rights to that FQHC, or you're providing service there, they're still going to get their per diem rate for that patient coming in. I think here it's something crazy like $400. But so there's, you know, assigning RVUs and billing out on the 1500 for that, you're going to lose money. So these are the only codes you get to bill at an FQHC, plus some exceptions. The CMS, great, but wait, there's more. These are the only codes, but there's some other stuff too. So these are the codes that go on the 1500. It's great, it's only 5. How many codes are in the CPT, AMA CPT book? 20,000, I don't know. That's way too many. I think it's like 3,000. 20,000 ICD-10 codes, 186 new ones this year. Anyway, exceptions. Technical component of the FQHC goes on the probably UB04. Lab services, DME, ambulance, telehealth distance site services, reimbursement code 780, hospice, and group. I kept that short, didn't I? Anything that is in the FAQs from CMS pertains to both FQHCs and RHCs together. They kind of lump them together even though they're not paid the same. Perfect. Place of service 72. Now, the more I learn about this, I'm like, okay, why is there place of service for a CAH if you're billing mostly on the UB04? Oh, okay, because if you go method 1 billing, the physicians providing the service is bill on a 1500. So they use the place of service, whatever that number was. Same thing with FQHC. There might be, you know, there are things outside the realm that are not covered by those 5 codes, which would go on a 1500 in addition to those. So you're using place of service for that. Same, not so much this. This is like the granddad of the alternate care settings. Rural Health Clinic Service Act of 77. I don't know about you, but I was in 7th grade in Mokina, Illinois in 1977. Billing and CPT coding was like so far beyond anyone's imagination back then, right? Okay, so we're going to increase the use of NPs, PAs, CNMs, because we have a dearth of providers who are for physicians who want to give up the bright lights, big city, I guess, and work in a rural health clinic. So they get an AIR for all medically necessary, face-to-face, primary, and qualified preventive health services. So primary health services. This is your front line before you send someone to maybe a tertiary care facility. So these are all the practitioners. And they're all billed out on a CMS UB04 with rev codes. So here's all the rev codes you bill with. There's that 0780, telehealth from originating site. I love that number. It speaks to me. It's a good number. Okay, so this is where it gets exciting, and maybe not so much exciting since we've all been there, done that, I hope. Only during the PHE, we have pages 64 through 71 devoted to FQs and RHCs. It does preface that these changes are not permanent. It says it in at least 2 of the answers of the FAQs they have on there. They made up some codes for us, which is great. Gave us even the payment amount. So if your code, if the thing that you want to do, if the medical service you wish to perform with a patient is specified on the telehealth list, that if you Google CMS, PHE telehealth list, takes you to the CMS website, And then you click on the URL right there in the middle of the page. It brings you up a file, the zip file that you download, open up, and there's an Excel spreadsheet in there. If that service is on that Excel spreadsheet, then you bill G2025 only. That's how you do it. And you get paid $92. It's pretty awesome. And that goes on the UB04. Okay. Please refer to this document here, SE 216. For online digital evaluation and management. I don't know if any of you have done this yet. I have not. I've known others that have. Like Telederm, I think. I'm not endorsing them, but that was like the first company. You take a picture of your bug bite right here, a little bug bite, and you're like, what is this? Should I come in? And one might do store and forward, but online digital evaluation and management pays more. There are 3 codes for that for a professional fee. For the RHC and FQs, there's 1 code, G0071. And I think everyone knows that became effective July of last year. They were allowing us to use another code, but it got switched over to this one. Big discussion about it in the FAQs. Bill once every 7 days. So it's kind of fashioned a little bit like the G2012 and the G2010. I don't want to confuse that with the prolonged care codes for E&M, G2212. Anyway, telephone documentation. So you use that other code, first one, G2025, to document. That is also kind of based on the G2012, which is, I hope I'm right, so many codes, so little time. So close in numerical sequence. Thanks to our friends at CMS. Love you guys. Anyway, so it's at least 5 minutes. And like the others, it's like that, the virtual check-in. You don't bill if it's originated from a related E&M or leading to another E&M within the next 24 hours or as soon as available, including one that's face-to-face for audio-visual. So that's what you document. I spent 10 minutes talking to so-and-so, hadn't seen him in 6 months, and I told them to keep taking their Synthroid, and I'll see him in another 6 months when the PhD is over. Bill it, Dana. Okay, so I pulled out FAQs that I've had to go to that FAQ site to get my answers so I could respond to folks. This one was from a friend of mine quite recently. Can a medical visit and a mental health visit be reported on the same day when furnished as a distance site telehealth service? Yep, can. And this is where the FQHC and RHC can be a distance site during the PHE. I have more on that later. See the suspense. I just keep it rolling along for you all. Question, how do we report distance site? Like that. Just like that, how it says on the sheet there. 52X. And then here's the URL to show you how to do it. So in the FAQ, it has another URL they want you to go to. They could tell you in the FAQ, but they're like, okay, we're telling you here, but for further information, go here further. I did that for you here. Cost report. Okay. For them that do pro-fee, primarily, the cost report is what you send the state or the feds. Okay, help me out here a little bit, folks. I know you're going to tell me it's wrong. But really, the cost report, say, for instance, if you employ a nurse in your medical center, let me think. Do I want to use nurse? Yeah, I do. I am putting them on the cost report as a cost to me as the medical center. I am putting my physical therapist. The thing is, during, if that nurse bills a 99211 as the lowest level of E&M, where say a patient comes in for an injection and they get a little bit of counseling that goes along with that and not just getting the stick, you can bill a 99211 for that. But you have to, the RN needs document in the chart, I counseled them, their arm might swell, it might hurt a little bit, give us a call, blah, blah, blah. That has to be in the chart for you to bill that extra code, which is awesome. Bill for everything we can. But if you're not billing for it, you're going to report the hours of that RN on the cost report. So what this is saying, how do we report this on the cost report? Well, we're going to put it on the cost report, like right what it says here. I know there are forms. There's so many forms and there are worksheets and lines. LINE 79, that's line 79. Supervision, okay. Who can do it? Who can furnish distance site providers? Everyone. Everyone can during the PHE. Are there changes to direct supervision? Yes. It's changed to use of interactive audio and video telecommunications. So it's not quite general supervision, but direct supervision is I can reach my doctor, I can reach my NPP, I can reach my PA via phone if I need to during the PHE. In a nutshell, providers can perform and get paid for providing distance site services. Providers don't need to be in a facility to do it. It could be at home, be anywhere. Patients can be at home. But, this is billing the government. So co-insurance and deductibles apply as they normally would if the patient came into the clinic or the hospital. So what's next? What's next post-PHE? Well, as we just said in the FAQ several times, it said everything's going to revert back. I was lucky enough to participate. Well, I listened to and then, did the clap thing on Zoom when the staffers said things that I liked. So even if the other PHE telehealth extensions are revoked, a lot of congressional leaders are trying to keep FQs, RHCs providers to keep it as a distance site provision. Why not? It's working. It's not even broken. We don't have to fix anything. Just keep it. So that is a primary focus. The rest of telehealth, maybe not so much. As we know, and I've said it before, there was if you Google memo to state governors, interim health secretary, January 2021, the governors were told that the PHE will most likely extend to the end of December 2021, New Year's Eve, and we will be given 60 days notice. So anyone thinking, oh, my state's opening up. Can I still see patients via telehealth? Well, we're not over it yet. We're not over, states are opening up, but there's still stuff happening in the hospitals. People are really worried about the Delta variant. They're expecting hospitalizations. So we're not there yet. But when we are there, they really want to keep FQs and RHCs as distance site providers. I don't know if you all have been aware, this was all these newsletters I get, everybody, everybody, Becker's, Health Matters, some other publications that I get delivered to my email box, were really promoting and discussing a reminder that 2 congressional members, and I think it was Klobuchar, someone else, they wrote letters to these people up here. They're here, and they wrote letters to people up here, a letter saying, hey, remember that stimulus bill we passed last year? We're supposed to be using that money to keep RHCs that might be on the brink of closing because of the PHE. What about we revamp them as standalone emergency rooms with some outpatient services? And on average, each facility could get close to $750,000. So there's the link for that. I don't know if anyone on this webinar is, facing this kind of thing, or, a freestanding ER might be super beneficial for your community if you had to close the RHC. Now, I know there are specifics about an RHC, like you have to be open 24/7, provide emergency care. But this would allow you to probably cut back on staff, work as an emergency room, and get increased funding for that so that you can save people's lives. They don't have to drive 70 miles to Tucson, Phoenix. They can drive 20 miles to that RHC they usually go to for primary care. So that's a cool thing. Call your Congress people. Tell them that they should do it. So here are the resources. I put in this huge, ugly Billing 101 location. It was a document I found on the ruralcenter.org. It was updated in 2015. It's called the Replacement Manual. I couldn't find a specific position for it on the ruralcenter.org site. So I've blessed you with the biggest, ugliest cut and paste in the world. So you're going to grab that whole thing when you get a hold of the PDF, which of course will be provided after this webinar. Paste it into your browser, and you're going to get a PDF document that comes up. It has all that stuff on there. I love these Billing 101 documents. They're lifesavers. The Critical Access Hospital fact sheet that MLN put together was for CMS. It's okay, but it's not as good as that Billing 101. And then for FQs, we've got the HRSA URL. We've got this strange Squarespace site. Somebody said, hey, I'm going to put some stuff up on Squarespace, write my own, start my own website. Anyway, there's a great fact sheet on there for FQs. And then there's a fabulous Billing 101 for us newbies. Semi-newbie. I've been chipping away at this for a couple of years now. Rural Health Clinic. Oh, there's another Billing 101 fact sheet. Chapter 13 of the Medicare Benefits Manual. It's got all the billing guidance. Broadband. 12:45. We'll have time for questions. I just want to mention broadband. I also was able to participate in a meeting last week where, broadband's important. And a fella from the Atlantic TRC, now everyone's going to text him and say Carol was not remembering his name, but I thought he was very informative and intelligent. He brought up this broadband mapping paper. It's pretty cool. It's a nice resource. I haven't read it, I haven't read it screen to, what do you say? You don't say cover to cover anymore. I haven't read it from beginning screen to end screen. It's not an airplane, it's my clothes washer. But it's a great resource. And then there's this mapping site. So I guess whether or not you get broadband is based on your census data. Answer your census. But they're trying to make a case for, don't base it on census. That's ridiculous. Just because you're in a low population area doesn't mean that you would not like to stream Netflix or talk to your doctor about your heart medication. So I thought that's a great resource and I wanted to share it with you. So now,
now it's questions
questions.
time.
Let me shut the door. I can't even hear because the airplane is landing.
Okay. So basically now that was a great talk, Carol. Again, very useful information. I love the fact that the chapter in the Medicaid is chapter 13. Whether that's lucky or unlucky, I don't know. But I just looked at that and said, oh, okay, chapter 13. So we do have questions.
Everything good about billing is in that chapter 13. So I think it's like the antithesis to unlucky 13.
Exactly. So we do have questions. Some of them I can maybe address if you can't address. But first one, how can consents be signed by patients via telemedicine? And if that's out of your wheelhouse, I can answer it.
In some areas, you can obtain a verbal consent and document it in the EMR. In some states, the need for consent has been waived during the PHE because telehealth is all you're going to get unless it's an emergency and you need to come into a facility. There's other things you could do. You could have a witness with the patient if you've sent them a consent and they've downloaded it and they printed it off. Witness them signing it, putting it in an envelope with a stamp, I hope, and put it in the mail. 3 different ways.
Putting it in the fax machine.
Or PDFing it and sending it back via email or through the EMR.
Yeah, great. So it is feasible. And just a reminder to people, this is your standard consent to be treated. This is not like an IRB approved consent. This is typically whatever your hospital gives to people to approve to be seen by a provider, treated, etc. And increasingly, hospitals are including a statement about telemedicine directly in there. So it's good. Is a 99211 able to be billed via telemedicine visits?
It depends.
Of course.
Check your state policies. As you know, I live in foggy San Francisco where it's a blazing 61 degrees right now. If an RN does call a patient, or it doesn't have to be patient initiated during the PHE, but if there's a phone call that's met where there's a smidge of medical necessity, it can't be like, don't forget to take your pills, don't forget to come into the office. It's going to be, I'm sorry to get the email that your arm has swelled up, please put ice on it. And you're giving them medical advice that an RN can give. So yes, it can be billed as a telehealth visit.
Good. You had a slide, RPM billed from CAH, and one before that. I thought we were under the topic of CAH, and you were describing how to bill under hospitals about walls, but then you said this wasn't for CAH. Is hospital without walls able to be used for CAHs and the PT/OT departments?
Yes. I'm sorry,
okay,
I
that was an easy
myself.
Answer. I like that.
I'm sorry I contradicted myself.
Straightforward.
Yes.
The answer is yes.
Yes.
For FQHCs, telehealth distant site services can only be billed during the PHE, public health emergency. I guess they want confirmation or.
Yes, thanks, Tricia. This is true. After, it's going to revert back to only being an originating site. And as I just mentioned, congressional staffers are hoping that they're quite rural states, Oklahoma, and I think the other one was Texas, that they retain that ability.
Cool. Is there a link for the presentation slides? Yes, if you go back to the top of the chat, Chris put it in there. And the slides, the recording, everything will be available in a couple of days.
Yep.
Chris
said he'll have it available by the end of today.
Wow, Chris, kudos to Chris. All right. I'm gonna give
I know
him a
people, yeah, they want to click on those URLs.
bonus. Let's see. How can an RHC provider be an assistive technology provider or an OTR? And then after that, I guess they left out wheelchair seating.
You know what? I think that'd probably be a good one for another webinar, Chris. We've avoided DME as much as possible. I know folks still need to come in person for fittings and other DME type things because it's so expensive. So I'm thinking, I don't think an RHC can do this right now. I think you still have to come in person, just due to the expense of these things.
Okay.
Even with the what is that diabetic boot called? Those you have to come in person too.
Yeah. Okay. Well, hopefully that'll change.
Yeah.
If we employ an NP for another facility we are running, can we get 100% reimbursement for the EMN if the provider is not at that secondary facility?
EMN. What does that mean?
I just put that abbreviation in there. Brianna, what's a EMN?
We can go back to that one.
Yeah, we can come back. Brianna, if you could put in the chat what an EMN is, we would appreciate it.
Yeah.
Can RNs bill, they can build whatever they want. They can bill for telehealth visits via Zoom or telephone.
Sure, but are they going to get reimbursed? Yes. Check your state's policies, and you can find them on the CCHP, Center for Connected Health Policy, ca.org website, and each state's requirements are listed on there. And if it's medically necessary, yes.
Yeah, and just be aware that Zoom does have two versions. One is sort of the standard version, and then one is the HIPAA compliant version. And depending on what happens down the line, it may be that we're all going to have to go back to that HIPAA compliant version, but we'll wait and see.
True. True.
Can FQHCs build the 4 CPT RPM codes during the PHE?
No, still not. Sorry.
No, that's good. Can you talk more about the potential and logistics for billing code 99421 after the pandemic?
Now that is the online evaluation and management, right?
Ah, yes, ENM, not ENM. Yes, now it makes sense.
Oh, what was that?
Well, back to Brianna's question about if we employ an MP for another facility and we are running, can we get 100% reimbursement for the ENM?
Oh, the
providers
evaluation
at the
and
secondary
management.
facility. I think that's what she was asking.
Well, you get paid at 85% of Medicare if you bill an NP for provider service. But yeah, sure.
Okay, why not? And then I guess back to the question about 99211 is a nurse visit. Is it allowed to be billed for a telemedicine visit?
Yes. And then back to the logistics of the 99421.
Yeah.
That is a non-PHE code. That was given to us in the 2020 physician fee schedule. So there's the 99421, 22, and 23 with different time components. So long live the 99421 through 99423. It's a great way for throughput for non-in-person necessary E&M encounters. And I think I shared maybe last year that, you know, as you're going through your EMR, your electronic medical record, and you're clicking through, you have to click a consent to say, yeah, I know I'm going to pay $20 copay for this. They might even ask you to pay it up front before you can submit your question. But they probably won't, because if the clinician who reviews your problem wants you to come in person or have a telehealth visit instead, or audio video, then they're not going to bill that. So it's going to live forever and ever.
We like forever and ever.
Yeah, yeah.
RN billing. Which CPT code can they bill, and would they bill incident to?
99211 only, ever. There's a really great thing I found specific. I will add it to the resources before Chris posts it on the website. Hopefully he hasn't been so proactive. I have a typo at the beginning. I'm not anal. But there's a really great resource if you Google what can an RN bill for? Or I'm an RN, what can I, you know,
Yeah.
How can I bill 99211? There's a really great resource that comes up, and I'll provide that to you on the resource page. Cool. I think Chris is trying to see if she can find it now. I see her like looking at it.
Okay, if she finds it, she'll put it in the chat.
Yeah.
John asked a question I'm not sure you would know, but so in HB 2454, that's an Arizona bill that recently passed. It requires medical insurers to provide payment parity for telehealth services using audio and visual features, and allows HCPs who are licensed out of state to provide telehealth services into Arizona under certain conditions. Is this currently being followed? My understanding is that it did pass into legislation and it is in effect. And so you should, it should be followed.
Yep.
It is probably one of the most liberal bills that has been out there.
It's amazing.
Yeah, it's great. We have time for maybe one or two more. Can the 99211 be billed by a medical assistant as well? I was always under the impression that an RHC could not bill the 99211. Is that only under the PHE?
I will get back to you on that.
Okay, that'll be the updated version of the slides that go online. All right, can you go to the next slide, Carol?
Yes. Yes. Oh, and Trisha, okay, I'll see if that is the link. Thank you.
stdtech.org. I hope there's more meetings to STD than the usual one. So anyway, thank you everybody for attending today's webinar, and thank you, Carol, for that great presentation once again.
We'll have to
ignore that virtual office hours for May. We did that, been there, done that. It was great too. Next slide.
Yes, April. Oh, sorry.
Next slide. No. Yeah.
I'm just reading the chat questions and
reading the chat, man. Okay. So this has been our Improving Access to Quality Medical Care webinar series. Once again, I hope everyone enjoyed it. Got a lot of useful information. Again, the slides, the talk, everything, the recording will be up on our website, hopefully by the end of today or as soon as Carol gets her updated slides to Chris. Check out our websites for upcoming webinars and events at www.telemedicine.arizona. Check out the Southwest TRC website as well. And next slide. And as I noted, your opinion is very valuable to us. It helps us guide the topics that we use on these webinars, when we have them, and so on. So please participate in this brief survey. When you log out, you're going to be taken automatically there. It takes like maybe 5 seconds to fill it out, maybe 10. So again, this series is made possible through the Arizona Telemedicine Program, the Southwest Telehealth Resource Center, which is funded by HRSA, as well as the Arizona Department of Public Health. So thank you all once again, and look out for future webinar announcements.
Thank you so much for allowing me to take up your lunch hour, and thanks for having me.
No,
Really
it's our
appreciate
pleasure.
it.
Always great.
Thank you.